Bye.
Well, good afternoon, ladies and gentlemen. It's wonderful to have Dr. Marisa Subrayan with us over here. And there you see her in the middle. I hope you do. We see her in the middle of our screen. Hi, Marisa. Lovely to have you back. And
hello, thank you.
My name is Peter de Jong, and his name is Professor Steve Jeffrey. It's we're getting to the end of this episode, this season of pelvic floor seminars. But we're going to be ending at the end of next month. That's November, which starts tomorrow. Just a quick thing. Next week, we have Professor Claudia Gray and Professor Priya Somapillai. They're going to be presenting the health effects of cesarean delivery, including the effects on the fetus. That's why Professor Claudia Gray, who's a pediatrician, will be with us. It's wonderful to have Dr. Marisa Subrayan. She's going to be speaking about the mental health implications of sexual dysfunction and pelvic floor dysfunction. Dr. Marisa Subrayan hails from Durban, and she's one of the very few female gynecological specialists based in Durban, in fact, and we look forward to what she's going to be saying. Just before she does her slides and speeches this evening, I'm going to ask Professor Steve Jeffrey. Steve, we've got a workshop in 2 weeks' time. Would you mind saying a few words about this? From time to time, 3 or 4 times a year, we have hands-on practical workshops here in Cape Town. In fact, in the Chris Barnard Memorial Hospital, where I am. It's a beautiful afternoon in this hospital. And Steve, would you mind saying a few words about our last practical hands-on surgical workshop for 2024?
Absolutely, yes, Pete. And again, thanks to everyone for joining. I'm just sharing my screen right now. I hope you can all see. But just to tell everyone about a live pelvic floor symposium that we're going to be running here in Chris Barnard on the 15th of November. And we've got a really great faculty coming. We've got none other than Peter de Jong. You can see he's holding, what are you holding there, Peter?
Well, I don't know.
Pelvis, I think, or something. Okay.
Could be.
We've got Frans van Wyk, who's an excellent surgeon. He's a urologist, but he's a really very good pelvic floor reconstructive surgeon. He's an expert in incontinence surgery, and he'll be demonstrating the vaginal approach to some of the prolapse issues. We have Lisa Kessner, who's also a urologist. And then we've also got 2 colorectal surgeons as part of our faculty. And we're going to be running through some important things, looking at an overview of incontinence, and then also looking at some live surgery where I'll be doing a sacrocolpopexy, and we're going to be demonstrating even some robotic surgery, rectopexy, and some bulking agents, some slings. And so if you really want to just a little bit of an update on pelvic floor and urogyne, you're welcome to come.
What date is that, Steve?
It's on the 15th of November. It's the whole day. It's a Friday.
Friday afternoon.
CPD
Starting in the morning.
CPD accredited 8 points,
8
and
points.
yeah, registrars are discounted. But we're looking forward to seeing all of you here, and we're all going to pop across for a nice drink in near the waterfront as well afterwards. You didn't know about that, Pete?
No, my wife
Yeah.
didn't mention that to me either.
Yeah. So yeah, but I hope she's not on. She might have heard that already now. But
You ruined it. You ruined it.
All right. Well, anyway, yeah, let's go straight to the session. Thanks very much, and Marisa can start. You want to share your screen?
Thanks. The session is sponsored by the Pelvic Floor Foundation of South Africa, and a special thank you to our two technicians, Wendy and Nadir, who are on this afternoon, and they're making these things run smoothly. So without further waste of time, mental health implications of sexual dysfunctions and pelvic floor dysfunctions. Dr. Marisa Subrayan of Durban.
Thank you. Good evening. All right, so let's get into this. Mental health is always something that seems very fluffy. People don't really want to address it. But even if you don't pick up a lot from this talk, I will let you know of 2 specific times to really pay attention. And you can choose to switch off for the rest if it feels like it's a little too much.
We wouldn't do that at all.
Same. I've got no disclosures related to the topic. So just to go into sex in general, there's this perception that women, as they get older, are either not sexually active or don't care if they have sexual dysfunction. But depending on what studies you're looking at, about 20% of women in their 70s are still sexually active, and about 18 of those in their 80s. But women throughout their age groups have lack of sexual interest at a rate of around about 30%, regardless of your age. And if you do have sexual dysfunction, this is going to impact on your mental health. These women have much lower rates of general happiness and much lower emotional satisfaction. If we look at surgeries related to pelvic floor dysfunction, many times we're looking at the anatomical success and resolution of what the surgeon or the doctor may feel is the real problem. But sometimes patients find completely different things in terms of satisfaction to what the doctor felt it was going to be. Most studies are looking at adverse events from the point of the surgeon or the healthcare provider. But patients may perceive sexual dysfunction either as a result of their pelvic floor dysfunction or as a natural consequence of their pelvic floor dysfunction, as something that they didn't ever anticipate. So we need to be talking to patients about this. There's quite a disconnect between what doctors and patients believe is a successful outcome. And women have stated in studies about pelvic floor surgeries that if they felt a recurrence of symptoms, if they had any form of incontinence or recurrence of symptoms many years after a surgery, they felt this was equally an adverse event as an ICU admission or even a death. And if you're going to perceive anything to be an adverse event, that's going to push up anxiety and depression. It's going to make you not trust the doctor that's been treating you and not be able to manage as a whole. We look at the physiology of sex. We need sexual arousal and we need orgasm. To get sexual arousal, we need voluntary contractions of the pelvic floor. If the pelvic floor has a hypertonic dysfunction, it's already sitting at a very high muscle tone. So we're unable to relax sufficiently to create multiple voluntary contractions and then reach orgasm. With orgasm, that's an involuntary contraction. So if your pelvic floor is so hypotonic that it's unable to create those contractions, that could mean anorgasmia, reduced intensity of orgasms, and prolonged duration to reach orgasms. There's an inverse relationship between genital arousal and pelvic floor tension. When you look at the cycle of pain, this is something that's discussed in terms of vaginismus or sexual dysfunction. But I also want you to think of it in terms of mental health, because it isn't just a negative effect that's happening to the physical body. There's also negative reinforcement from the mental side. If a patient experiences pain or even has memories of pain, negative sexual experiences, sexual misconduct, this can even be a patient who has negative memories of having gynecological exams or having birth trauma during deliveries of their babies. This fear of pain could cause them to avoid sex. Even feeling friction from the penis or against the vulva can create further pain and exacerbates the fear and the avoidance of sex. It's more difficult for these patients to become aroused, definitely more difficult for them to achieve orgasm, which is going to further create more pelvic floor hypertonicity and just let that cycle continue. So the mental aspect of pain needs to be addressed so that the cycle can be broken. And if we're only addressing this in the way of local anesthetics, telling someone to deal with it, or only providing a surgical solution, then we're missing a large component of holistic care. In patients that have had hysterectomies done, now these were hysterectomies across the board, whether it was done abdominally, laparoscopically, robotically, whether it was ovarian preserving or ovaries were removed at the same time of the hysterectomy, there was an overall improvement in pelvic floor function. In terms of sex, there was no change in sexual function for the first 3 years. But after 36 months, regardless of what the indication was for the hysterectomy, and regardless of what type of hysterectomy it was, patients saw a significant worsening of sexual function. It's not attributable to age, and it's not attributable to whatever the initial indication was for the hysterectomy. It is important for patients to also know that this is something that they can experience. Hysterectomies get done for many reasons, and there is often just a patient who's trying to get rid of bleeding, not deal with her fibroids or endometriosis, but she may not realize the sexual or mental impact that's going to come possibly from having that hysterectomy done years down the line. We know that surgery for pelvic floor dysfunction is absolutely beneficial, but what we don't focus on as much is how we can benefit patients who have existing sexual dysfunction and how we can improve their sexual health. They may already be preventing themselves from having sexual relationships or trying to prevent certain sexual experiences where they might experience incontinence. And if we can get them to having the type of surgeries, the type of treatments that they need for their pelvic floor dysfunction, they can start to enjoy a positive sexual life. If patients had surgery for pelvic floor dysfunction, they had improved quality of life, improved general well-being, and improved sexual function. And the greatest improvement in sexual function was for the patients that were experiencing sexual incontinence. Though that can be fecal incontinence, urinary incontinence, or queefing. If we don't go towards surgery, we may also then consider conservative options to help patients. So if you've got a patient that's got severe pelvic organ prolapse, vaginal pessary might be an option for them. Advanced prolapse in patients that had a pessary used were the ones that had the greatest improvement in mental health outcome. 90% had symptomatic relief in terms of their genital symptoms. They had a 75% overall satisfaction, and 93% were continuing to use this at over a year. Most people think that the benefits the patients were getting were because of the vaginal pessary. But in qualitative studies that were done, the patients found the greatest benefit because they got to have more visits with their doctor. They got to speak more with the doctor, and they got to be involved with a multidisciplinary team. Sometimes mental health management is not the way that you think it's going to be. And even though you need to see the patient over and over again and might be frustrated with seeing them, you are providing medicinal care to that patient, even when you don't think you are. Pelvic floor dysfunction is definitely associated with sexual dysfunction. But if we're not looking for the sexual dysfunction, we may not even know that it's there. If a patient spontaneously reported their sexual dysfunction, they were only going to do that in about 14% of cases. But if the doctor prompted them during the consultation, 55% reported sexual dysfunction. Now, this didn't come out of thin air. These patients had sexual that I shouldn't speak about it. They may have even been told by other gynaes that this isn't an issue. They should just put up with it. They may be so depressed, they may feel there's no hope, So it is important that we ask to first figure out, is there sexual dysfunction, before we can even start to address how we're going to solve it. The main predictors of sexual dysfunction with pelvic floor dysfunction was pelvic organ prolapse, stress urinary incontinence, overactive bladder, and fecal incontinence or fecal obstruction. In a large study that was done, the majority of the patients were postmenopausal at 68%, 74% were sexually active, and 54% had had sexual activity within the last month. In that study, 46% of patients showed sexual dysfunction. And that means that a large majority of the patients sitting in front of you, about 1 in 2, are experiencing this, which fits with the previous study that I've showed you, but we are not asking enough questions. Major factors for severe sexual dysfunction were those involving fecal incontinence or fecal obstruction. And what's often not addressed are things like relationship discord, partner satisfaction, or genital atrophy. If a patient has genital atrophy, on top of having pelvic floor dysfunction, they might feel like surgery is supposed to solve everything and overlook things like using local estrogens as a long-term measure to try to reduce the component of genital atrophy. The patients that had sexual dysfunction were also more likely to have ongoing reduction in orgasm frequency over many years, as well as increasing duration to reach orgasm. So it isn't just that having the pelvic floor dysfunction gives you a certain baseline of sexual dysfunction. This will accelerate at a faster rate than those that don't have pelvic floor dysfunction. Exercise is definitely beneficial. So especially pelvic floor exercise, these are going to improve sexual function and improve sexual quality of life. If you're using mind-body principles like mindfulness, this will help menopausal symptoms and also sexual quality of life. But there are also a lot of studies that have been done that are quite inconsistent. And that's largely been because there hasn't been a good definition of what is exercise, the duration of it. There hasn't been a good separation between whether patients should do strength-based exercise or do cardiovascular exercise. They also aren't looking at the baseline of the patient's fitness to see how a certain amount of exercise would improve sexual function. And I think as more data comes out about those, we'll be able to get a better idea and see that exercise has more of an effect on sexual function than what we've already seen. Cognitive disorders occur at a higher rate with pelvic floor dysfunction than in the normal population. There's about a 15% prevalence of dementia and cognitive impairment in these patients. Often the issue is not something that's dealt with by the actual patient because they have the dementia. It's the caregivers and the family that are the ones that have to deal with what's going on. The patient is often angry, frustrated, not understanding what's going on, and can become terrified with having fecal or urine incontinence. These patients have a significantly worse quality of life, especially if we are combining cognitive impairment with an existing pelvic floor dysfunction. So screening patients for things like dementia early on, when you do find a pelvic floor disease or dysfunction, is something that can then allow patients to be screened, referred early, and allow caregivers and family to have a better insight into what to expect later on. 1 in 3 postmenopausal women report having depression. But if you're looking at studies, generally the baseline rate of depression is 17%. Now that can mean 2 things. 1, there are many more women that have depression, but they're not reporting it, they're not seeking help. And I think that's a major component. But it may also be that a lot of women are experiencing symptoms that they may have accidentally been told is depression, even if it's not. In the perimenopausal and postmenopausal period, there are a lot of changes in mental health, increases in irritability, frustration, and much higher rates of anxiety and depression. Patients are often told by their primary healthcare providers, you have depression, and placed on an antidepressant. But sometimes we need to also consider whether this is not just depression, especially if there have been no other traumatic events, no triggers, no previous mental health disorders, and no family history, that possibly these patients may be better suited with addressing this with menopausal hormonal therapy. In patients that have pelvic floor dysfunction, those that are more likely to experience anxiety and depression are ones that have family history of mental disorders, stress, traumatic experiences, poor sleep, poor socioeconomics, or comorbidities. I don't know about you, but that covers just about every patient that comes to my rooms. So everybody should be screening for anxiety and depression. You don't have to be the one to manage it, but if we aren't asking the right questions, we can't refer the patients to the right place. If a patient already has an existing mental health condition, then certain pelvic floor dysfunctions created exacerbation to different degrees. The highest cofactor was chronic pelvic pain by far, and other things like urinary incontinence and fecal incontinence were milder cofactors to pre-existing mental health. I was expecting a much higher rate of anxiety in patients with fecal incontinence, but what I actually came across were patients with urinary incontinence had significantly higher rates of anxiety than the other patients that had different types of incontinence. Patients with urinary incontinence have twice the rates of depression and panic disorders. They are also more likely to have more severe depressive episodes, 3 times the rates of loneliness, and reduced quality of life and functional capacity. The chronic pelvic pain patients also have a lot of depression and anxiety. They also go back and forth between many doctors, seeking second opinions, and often never finding a resolution of their symptoms, which adds further anxiety and depression. Those with fecal incontinence are more likely to have severe mental health disorders, even though a lower percentage of those with fecal incontinence have mental disorders. The depression rates are proportional to the severity of fecal incontinence, as well as poor socioeconomics. Lack of disclosure is a really, really big issue because patients might feel embarrassed. They might feel shame. They might feel shy to discuss this with their doctor. They might not know if they're supposed to discuss it with their GP, their gynae, their best friend, or whether they're not supposed to discuss it at all. And there may be a lot of false beliefs around what it means to have a mental health disorder because there's a lot of stigma, or that they are going to be placed on an antidepressant if they describe anything to the doctor. A lot of patients also have a fear that they will require surgery for a pelvic floor dysfunction that can further lead to more anxiety and depression. Although there have been studies done, we need a lot more studies to address the mental health effects of pelvic floor dysfunction, because currently what we're doing in terms of medication and surgeries, we are seeing that these patients' needs are not being fully addressed. We might get surgical success, we might get a short-term improvement, but you see these patients coming back, describing symptoms, even though there may not be something actually there objectively on the test. So what do? Every single patient reports that they want an empathetic doctor, but I couldn't find studies that describe what an empathetic doctor is. Sometimes it can be a little easier. Refer your patients early. If you're having a patient that's coming back to you and there isn't something that you can do, send them over to a different specialty, send them over to a psychologist or a psychiatrist, because there is more that needs to be addressed. I also found it interesting that in one of the studies, patients found significant improvement in anxiety and depression if we change their surroundings. And that was an improvement in the doctor's rooms or an improvement in their home. So this might be a reason for you to do up your reception area to make your patient feel a little happier. Obese women are very prone to pelvic floor dysfunction. And what we found is that they have a pretty high quality of life. And I wasn't expecting to find that. But in comparison to their high quality of life, they had a much lower sexual function score. We were comparing patients of an average BMI of 25 to 35. So that this isn't looking at patients that are of a healthier weight or even underweight. We're just comparing average of overweight to average of obesity. The study hypothesized that the reason why these women had such high quality of life in comparison to a low sexual function was that women who are obese are less sexually active, focus less on sexual activities or improving their sexual function. they would then find more joy or more experiences in non-sexual activities, which gave them more quality of life. I don't know if I agree with it, but it was just something I came across in the study. Postpartum pelvic floor dysfunction is something that is very common and underdiagnosed. And screening is something that should be starting before the patient ever gets pregnant. If you've got a patient that has risk factors for pelvic floor dysfunction before they have their pregnancies, or even if you find them at a preconception visit, in their pregnancies, having stress urinary incontinence, obesity, patients that have had previous sexual abuse or trauma to the pelvic floor, please consider that they may have these issues postpartum as well. There are not only the adverse medical health effects of having a pregnancy, being a new mom, and taking on all these new responsibilities, but there's the added feeling that your body has deserted you, that your body has betrayed you. If you're having to deal with those added extras, this is going to affect your bonding with your baby. So we do see poor early attachment, lack of latching, poor breastfeeding, and low birth weight, a low gaining of weight in neonates. Also, long-term, these patients tend to have worse postmenopausal mental health symptoms, which is something that one would not generally correlate. I'm putting oncology as a pelvic floor dysfunction, even though it may not seem like it is. And that is because cancer just by itself, having that diagnosis, having to figure out what you're going to do and going through the treatments and figuring out how to be a cancer survivor is an emotional stressor by itself. Besides that, whatever we're doing to try to treat the cancer is going to affect the pelvic floor and can create pelvic floor dysfunction. We're going to be doing surgeries, and depending on the staging of the cancer, we might have to do extensive debulking surgery. There may be lymph node dissection, which is going to cause chronic swelling. If you have to have chemotherapy or radiation, you might get pelvic floor fibrosis. The vaginal canal might be narrowed or shortened. And many women have to be on anti-estrogenic medication for many years after resolution of the cancer, which has a further effect on their pelvic floor muscles. We go into sexual abuse. Sexual abuse affects the pelvic floor, not only after sexual abuse has occurred, but for decades to come. In a study that was done, we looked at sexually abused patients and then the controls and compared their pelvic floor tone when they were shown different video stimuli. In patients that were shown anxiety-provoking videos, they correctly had a hypertonic contractile response. And when they were shown sexual videos, they had relaxation of their pelvic floor, which would allow for voluntary contraction and arousal. Even sexually threatening videos did not create as much of a contraction and stress response as anxiety-provoking videos. But in patients that were sexually abused, no matter what they was shown, they had a negative response. So you've got somebody that whether they are seeing something anxiety-provoking, a positive or negative sexual video, and that pretty much covers everything you see every day on social media, on TV. These patients have a constant negative feedback, a constant stimulation of their pelvic floor. So they can't get resolution from something that may have happened to them many years ago. The reality of sexual abuse is that it is much more widespread than what anybody thinks it is. And we need to stop acting like it doesn't exist. 2/3 of girls below the age of 18 years old will experience sexual abuse or sexual misconduct. That means that your daughters, your sisters, your nieces, your friends, if there are 3 of them, well, then 2 of them have experienced something like this. That also means that 2/3 of the patients that come to your rooms have also experienced sexual abuse and all of the effects that come with that. In a general population, 15 to 25% of women reported sexual abuse, but there are a large amount of women that might not feel comfortable to disclose that. 25 to 58% of women with pelvic floor dysfunction reported sexual abuse. And you've seen the lifelong detrimental effect that this has not only on the patient, but also on her relationships and sexual function. We need much more research into the way that sexual abuse affects pelvic floor dysfunction, gynecology, and women's health in general. But the issue so far with the studies that have been done is that there isn't really a definition of sexual abuse that is able to be used consistently throughout all of the studies. There also isn't much of a differentiation of whether the sexual abuse was vaginal, oral, anal, or a combination. There's no assessment on the severity of sexual abuse. And how do you begin to assess severity in terms of physical, emotional, whether this was at a young age or an older age? We also often don't assess the chronicity of the sexual abuse and just ask if it did occur or didn't occur. They also don't focus on how long it took from sexual abuse occurrence until the development of pelvic floor dysfunction symptoms. Sexual abuse is often self-reported, and that's going to give it the chance of having recall bias, making it less able to be taken seriously. But there's so little objective data on sexual abuse because the patients that are admitted or need reconstructive surgery, by definition, are the most gruesome or serious sexual abuse. The ones that may have not required hospitalization or surgery have still occurred, but there'd be no records of these. Sometimes severe sexual abuse may be seen at places like the Teddy Bear Clinic, where you would have records of that, but there's a large amount of sexual abuse that's also not reported, and we have no data on that. In the studies that have been done, there's also a large amount of incomplete data. Patients tended to be able to fill in their current symptoms very easily, but when there was data related to the sexual experience, patients would start to fill in data and then stop. Or patients would fill in a single aspect of the sexual abuse and then stop explaining the rest. I'm not sure if patients are remembering or not remembering. I'm not sure if patients are re-experiencing and feeling triggered during the studies, or whether there's so much shame that somewhere in the middle of their research, they no longer want to even complete the study. Sexual abuse has widespread effects across different specialities. The most common effect seen in sexual abuse patients is menorrhagia, dysmenorrhea, and irregular menses. And that covers a large amount of patients that you are seeing in your rooms. These patients need to be screened. Yes, they may have a pathology that is physical, but if all we're doing for them is providing an oral contraceptive or taking them for a surgery, then we're missing where sexual abuse may have occurred and how we can address that in terms of mental health and how we can prevent them from dealing with the future pelvic floor dysfunction from this. About 70% of sexual abuse patients report dyspareunia. Many have chronic pelvic pain, and they are more likely to have a hysterectomy in general, even if there was no pathology found. And this is usually for the chronic pelvic pain patient. In terms of urology, they have much higher rates of overactive bladder, of UTIs, painful bladder syndrome, and interstitial cystitis. So that might be the patient that keeps presenting to the GP and keeps getting prescribed oral antibiotics. You may send off samples yourself, you may be doing swabs, there's nothing found. They need to be assessed not only by urology, but also by psychology or psychiatry. In terms of pelvic floor dysfunction, they are more likely to have fecal incontinence, chronic constipation, chronic pelvic pain, and require vault prolapse surgery after initial pelvic floor surgeries were performed. Obstetrically, they're going to need more C-sections, more episiotomies, and have more obstetric anal sphincter injuries. Sexual child abuse has an even greater effect than sexual abuse later in life. They'll have all of the issues that I've already described, but to a higher rate with a greater severity. And another component is that these children also tend to have a higher BMI and a higher waist circumference. Childhood obesity is something that has detrimental effects lifelong. It's everything from children that are more likely to have lower IQ scores, higher rates of asthma, they're more likely to have pneumonias and hospitalization. They are more likely to experience gestational diabetes when they have future pregnancies. they're more likely to have hypertension, diabetes, dyslipidemia, and heart attacks or strokes early in life, simply because they had obesity in childhood. Patients with sexual abuse experience exacerbated disease perception. The way that you might experience that in your own rooms is the patient keeps complaining of something, even though there's nothing there. The patient keeps complaining of more pain. The medicine isn't working. The medicine used to work, but now it doesn't. Everything I do doesn't help. As frustrating as that patient is, it is true to them. They describe a 12 to 23% higher disease severity, even though they have the same pain scores and the same anatomical assessment. And they have a markedly worse quality of life, not only because they have worse symptoms and the current treatments can't help them, but because when they do seek healthcare, they are often told there's nothing we can do because gynaes have already exhausted all the treatment options that they can use. These patients have high tone dysfunction and are more prone to pain and high resting muscle tone. And if they haven't already seen a pelvic floor physiotherapist or been assessed by a pain clinic, that also may be a referral besides psychology and psychiatry. Doctors reported a lot of discomfort in taking a sexual abuse history, and even more discomfort if they had to take this history from an older woman. But we just need to do better for our patients. It really is our responsibility to be the ones taking sexual histories, taking sexual dysfunction histories, asking about sexual abuse or any negative sexual experience. If you are going to ask a patient a comprehensive medical history, that has to include a comprehensive sexual history, and not just once. If you're going to be seeing a patient year after year, even if they don't have a pelvic floor dysfunction, please remember that sexual assault and sexual abuse continues to happen throughout your life. It can continue to happen even with your husband or your current sexual partner. It can continue to happen because it's most likely to occur from friends and family members that are most known to you. And within a year, just as you reassess whether patients have changed medical conditions, medication, if there are any new surgeries that have happened, please also assess their sexual history. Currently, we are not doing right by our patients that have had sexual abuse in their life. We know that the treatments we give them are not enough. They are having ongoing symptoms. They are having ongoing pain. Their mental health concerns are much more difficult to address because there may have been many more years of ingrained negativity and taboo towards sexual abuse. They may have had the people that they trust, like family members or doctors, not trust them, and they've squashed it all down. So we need to be the ones that are going to figure out that this is occurring in our patients so that we can be able to promote more treatments, more studies, and be able to help these patients. If you are having patients in your rooms and you are not seeing a half to 2/3 of them reporting to you that sexual abuse has occurred, then you are missing something. But as we go along, this is something that's going to affect us for decades to come in all of our gynae practices. And we need to be more open to how sexual abuse affects pelvic floor dysfunction and sexual function, as well as all gynae health in general. And that's it. Ooh.
Thank you so much, Marisa. Thanks.
You're welcome.
You've really reminded us about, some of our deficiencies as, well, firstly, as urogynecologist. I mean, you've highlighted the important physiological and social issues that we sometimes overlook. As a surgeon, you want to see the patient, book the date for surgery and get the case done and get out of your office, which is maybe very brash to say things like that, but maybe that's a mistake we make a lot. And obviously, you've highlighted some of the issues around the whole emotional and psychological issues associated with sexual dysfunction, but also pelvic floor dysfunction, incontinence, prolapse, self-image issues. Those are big issues that are underemphasized. So yeah, what do you think, Pete?
Marisa, I think that, Steve, thanks for those words. I just think that I've got a question over here, Marisa.
Sure.
These issues are highly technical. Some people find them highly technical. And the question that I have over here is, are these issues to be dealt with by the general gynecologist, or should we refer to a specialist like yourself for management of sexual dysfunction?
So like I said on my slide, it's everybody's responsibility. If you're a healthcare provider and you can screen a patient, you've already done the hard work. All we want is screening. Once we know that there's an issue, then we can start to figure out the next direction for the patient to go in. But if a patient doesn't know why they are being referred, that often leads to distrust between the initial provider and the one that they are referring to.
Right.
So ask the questions, screen first, tell your patient, you know what, I'm going to send you to someone who's more experienced in sexual dysfunction, or I'm going to send you to somebody that deals with these issues more commonly. I'm the one who does the surgery, and then they can move on and get further help.
Yeah. We have quite a few general practitioners and family physicians logged in this afternoon, and many of them have made a speciality of this. And I think it's important that people that have,
Can I say one thing now that I know that there are more GPs joining on?
There are lots.
It's not your fault, GPs. I'm very sorry for this. But if you have treated a patient for decades, if you're treating their husband or sexual partner, if you have known them since they were a little child, even if you ask the right questions, they might not give you an honest sexual history. That's not your fault. It's just a different kind of relationship that's been formed. Sometimes it's easy to speak to someone you don't know about the most difficult issues, and very difficult to speak to someone you've known for 10 or 20 years.
Yeah, because they are part of the family and you don't want to necessarily disclose, as you said. Steve, there's a question there.
I think this is quite a good practical question, and it's by an anonymous attendee. It's but how best to tell a patient you're referring her to the psychologist when she couldn't
very openly
the symptoms? I do find that, I mean, that is sometimes a bit of a challenge getting the psychologist or psychiatrist on board. There's cost issues, practical issues, but I mean, it's important. So what do you suggest with you?
How best to tell a patient to go to a psychologist? Because she might hear you saying to her, you're nuts, whereas you just feel you might need special input.
So I'm very open with my patients about the little bubble that I can provide of care to them, in the same way that they see their general practitioner for completely different reasons to why they're coming to see their gynecologist, to why they might take their child to a pediatrician. Each person is an expert in their different field. If the patient feels that what you're saying is they're nuts, they might need more time to process what's going on. And that's often a denial and defense reaction. It means that there's even a better reason for you to refer those patients.
Yeah.
If the patient has a positive response to it, but might feel that financially this isn't something that I can manage, there are a lot of support groups online, even Facebook groups, Instagram groups, TikTok groups. There are different free resources on websites online. It isn't as individualized, but it's something that can start to help them to open up about what may have happened and how it's currently affecting them. And if that's positive in the privacy of their own home, they might then come back to you and say, okay, doc, I think I'm ready to see a psychologist. Psychologists are also a lot cheaper than seeing a psychiatrist, and patients also don't have as much fear that they're going to be placed on an antidepressant. That's often a big fear for them.
As you mentioned, in general terms, we have another question over here. Do you think patients can get help from online resources, or is it in general terms better to have face-to-face consultations?
Face-to-face is much better because you need to open up the most vulnerable, traumatic experiences of your life. And we're not going to get deep down to the nitty-gritty if you're doing that in something that was designed for a general population. All of us have had a different combination of upbringing, traumatic experiences, positive experiences. We have different defense mechanisms in how we address those. And so you need someone who's in tune with that and working with you instead of something more generalized may work against you accidentally.
Yeah. Marisa, another question over here that's also popped up. If a woman has been sexually disturbed and sexually molested as a child, does she have a good outcome, or is she forever damaged in that respect in terms of her sexual dysfunction?
There are many more women that are forever damaged, and the greatest improvement or the greatest outcomes are those that receive psychiatric care very soon after they have sexual abuse. So if you have had more time for your pelvic floor to reinforce this, for more negative sexual experiences, for more triggering or nightmares, for long-standing anxiety and depression from the sexual abuse, that's a lot harder to unravel and retrain your body to see sex in a positive way. Some of these women might hypersexualize. Some of these women may have learned to fake having adequate sexual health. But if you start to dig a little deeper, they are often trying to do what is socially acceptable or do what is necessary to keep their partner happy rather than what they feel they would want sexually.
Right. The final question over here that's just come up is anonymous over here, feels that you're a person that is certainly adroit in the subject of sexual function and dysfunction. Do you have anything on the horizon that would be of use to women with low libido? I think they mean any pharmacological approach, or is this always going to be slightly more, shall we say, subtle and nuanced?
You have to individualize your patient. There are certain situations like hypoactive sexual desire disorder where low doses of testosterone can be used, but things like Vyleesi are not available in South Africa. So
what is that? Vyleesi?
Essentially a female Viagra. So it is available in America, but it's not available in South Africa.
Is it coming?
It's not. It's been around for some time. It's not coming here. So there aren't enough studies and there isn't enough focus on sexual dysfunction in women for us to create the correct kind of medication to solve it. It's definitely a big problem. But
it's a huge problem because
I'm not sure
when
why
I
we're not
speak to women,
fixing
you'd be
it.
surprised how many say, I have, well, they don't call it hyperactive sexual, they just say low libido. And I thought to myself, I'd be a billionaire if I had some form of intervention in a tablet form that could
Please find it.
Yeah. So it's not, Vyleesi is not coming to these shores.
To my knowledge, no, it's not coming. Maybe others might have a little more information than me.
Steve, have you heard of Vyleesi?
I have. Yeah, I mean, it's on the social media, etc. But yeah, and I mean, it's obviously got a lot of hype in the US, but
does it work?
It's regrettable, apparently on the social media, and people talk about it working, but I mean, it's regrettable that they don't place more emphasis. I always say that a lot, if a lot of these problems we dealt with were suffered by men, we would have a solution long ago. I mean, if you think
Absolutely.
about all issues that we have, that we see, the investment in research and development is almost disintegrated.
But Steve, it's a huge problem, and I'm sure that if you said yes, Agent X, that's good for addressing this problem, you would be an extremely wealthy man. You'd be able to have 2 Porsches.
Yeah, well, I mean, I just think it's not suffered by men. So, they're just not putting money into female health like they do into men's health. I mean, if you think about orthopedics, cardiology, all these things that get, men get, I mean, Discovery will pay 200,000 Rand for a joint replacement without any hesitation. They're trying to for a bit of Balcomit for women who's leaking, and you have to write millions of motivation letters. So so that's my soapbox, and we do struggle. Maybe I'm oversimplifying the matter, but
no, it's true. It's true.
Yeah.
Well, Marisa, we've had a wonderful afternoon. I'd like to thank you very much indeed for the time you've taken, the effort you've put into your presentation. It's been very well received. And I'd like to, on behalf of the Pelvic Floor Foundation, give you a great deal of thanks. And also we'd like to mention that Nadir, our trusty assistant, a colleague and technician, has a birthday today. Happy birthday, Nadir, and many, many more happy returns. For those of us that celebrate Diwali, do you celebrate Diwali, Steve?
No, not actively, but you know,
Passively.
we do have fireworks and things going off in our neighborhood, so absolutely.
But that's called Halloween. We're talking Diwali.
Well, they go off for don't be confused, you know, they're happening at the same time. So
Well, Marisa, it's been wonderful having you this afternoon.
Thank you.
I'd like to, on behalf of all the people that have logged on this afternoon, they've got information from you on this sexual function topic. A great big thank you. I look forward to seeing the people next year. Hang on, there's one more question, Steve. What does that say?
thank you for the presentation. How do you deal with doctors in tertiary institutions who refuse to accept patients? Sometimes it's hard as you're sitting in a district institution where resources are limited
Without help.
Yeah.
Steve, I think that's where you would actually use the resources that Marisa has referred to, online resources, and in that way you'd be able to assist patients.
Absolutely. Difficult subject. Yeah.
Good.
Yeah. But thanks so much for the question.
Thank you, Marisa.
Yeah.
Safe home.
Thank you.
Once
Thank
again,
you.
it's been wonderful having you over here. I'd like to thank our sponsors, and we look forward to having you all over here. Same time, same place next week. Good night, and thank you.
Thank you very much. Thank you.